We're back on the record. I think, Josh, did you want to make a comment before we move on?
Boy, do I. So I'd just like to repeat something that both Laura and I stated at the enforcement and compounding meeting in January, which is, there still seems to be a misimpression that's been reflected in some of the materials and some of the statements that have been made here today, that under current law, both in a clinic environment and in a licensed facility environment, the only persons that should be involved in stocking an ADDS are a pharmacist, or in those certain circumstances where you're using cards or other cartridges, it can be done by other licensed pharmacy personnel under the direct supervision of a pharmacist remotely. But all of this talk about nurses or wholesalers doing stocking of these ADDSs is not authorized under current pharmacy law, and this statement that somehow the board is changing the law to take away the ability of nurses or wholesalers to do that is not accurate.
Thank you, Josh. All right, we'll move on to the next agenda item. We're very fortunate to have Senator Hernandez here, and he is asked to address the board and make some comments. Senator Hernandez has been the author of Senate Bill 493, which the board has now almost fully adopted. Travel medicines we finally approved and moved forward today. So we are very fortunate to have him. Senator Hernandez, welcome.
Well, first of all, thank you very much, Madam President and board members, for allowing me to spend some time this morning with you to kind of talk to you a little bit about pharmacy, what's going on. But I think more important, SB 493. So what I'd like to do is thank you for almost implementing all the regs, and I think you're almost there. And I know it's been a long process, but I cannot stress enough the importance of this bill. But before I do that, I think I would like to spend a little time and talk to you about how it came about, the process, the political process, but more importantly, the effect that that bill not only is going to have in California, but throughout the United States, throughout the entire country. So when I was elected to the Assembly in 2006, I was given a subcommittee on workforce. And very, very early on, this is even pre-Affordable Care Act, I realized that we have a huge workforce shortage. But not only do we have a workforce shortage, but we also have a distribution problem of providers throughout the country, throughout California. Fast forward, we have the Post-Affordable Care Act. Yes, there's a lot of controversy what's going on right now with what's going to happen to it. But we had a huge influx of patients into the ACA. We had a huge influx of patients into Medi-Cal. But more importantly, we have a huge access problem to primary care. So my role as chair of the Senate Health Committee was three things. Number one, the successful implementation of the Affordable Care Act, access to everybody, and controlling healthcare costs. But to get access, we had to look at how we were going to utilize providers to make sure that's going to happen. So if you look at primary care providers, I mean, the workforce right now, it's so undermanned. In order to get enough of them, we'd have to increase the number of medical schools, which was very difficult to happen. Even then, the workforce wouldn't be available for 10, 12, 13 years. But over the years, I've had the pleasure of visiting numerous pharmacy schools, understanding the profession, the education, and it was only natural to start looking at pharmacy to fill that void in primary care. And if you think about what a pharmacist does now and their training, undergrad requirements, postgraduate work, doctorate degree, residency programs, pharmacy is a natural fit to provide primary care in this state, to fill that void. And if you look at the workforce, the number of pharmacists in California, in the areas that they can serve, and I've said this over and over again with the education of a pharmacist is so overeducated and so underutilized in our healthcare system that I felt that something needed to be done. It was a long process, meeting with the various pharmacy associations, consumer groups, moving the bill. It was contentious at times, but I'll tell you, this is one of my key signature pieces of legislation, you know, along with the many things I did on healthcare, up there with I'm most proud of, one of my most proudest is changing the smoking age from 18 to 21. But this bill is one that I really speak highly about, and the reason why I wanted to come and speak in front of the board. Yes, the governor signed it several years ago. Yes, it was a long process to get the regulatory process put into place. But let me tell you what's going to happen is you are now going to have pharmacists that are going to be able to provide health care, be able to provide primary care and be looked at as professionals and be reimbursed hopefully someday for their services. Here's the other exciting thing that I've seen. You are now having pharmacy schools being built in this state, and their education is revolving around 493. The other thing that I'm just ecstatic about is other states are starting to look at implementing bills similar to this, and you're going to see this huge transformation in this profession, and it started in California, and hopefully it'll go nationwide to really revolutionize the professional aspect of what you guys do, but more importantly, how pharmacists are going to play an integral part in our healthcare system in this country, and you will permanently be doing this because of SB 493. And I thought it was that important for me to come and address the board and thank you for all the work. But I will tell you, though, I did have a couple of concerns and a couple pauses to be here, is I thought I was going to be grilled by one of your public members, Ms. Munoz. No, she's constantly texting me, giving me a hard time, and if I don't go see her kids at the ball fields, she gets upset at me. But no, all kidding aside, it's truly an honor just to be here in front of you. I'd be more than happy to open up to any questions if you'd like to discuss the bill. And I'm sure you guys know I'll be carrying, I don't even know the bill number, your pharmacy bill.
I happen to know it now.
Yeah.
SB 443.
I'm horrible at my bill numbers, but I will be carrying a pharmacy bill, so it's a sponsored bill by you guys. So I'd be more happy to open up to any questions.
Thank you.
I'd like to thank you for offering the bill.
Thank you.
Very much.
Do we need to do anything about Ms. Munoz about 443, or is this something you can handle yourself?
Well, I will tell you, you guys have the biggest advocate because she has a direct line to my cell phone, and I always answer her calls.
A pretty demanding daughter, huh?
I want to say that clinical pharmacy has been around for a long time, and that's how they started the PharmD degree program, because they want to expand the scope of practice to pharmacy. And all along, it's all talk, and nobody really pegged it together, and you were the one who put everybody together and carried the ball and ran to score. So I really think the profession really owe you a favor, and really proud about you.
Thank you very much.
California has always been a leader in healthcare. What are you hearing from other states? What's been the impact of Senate Bill 493 that you think will happen nationwide?
So I'm hearing anecdotally other states are looking at it. A lot of states are looking at the language to move it forward. I think they have to figure out the politics of that particular state, where the opposition is going to be. But you're starting to see most of your schools and colleges of pharmacy are graduating young individuals who are educated and want to do this kind of care. They want to get out and do patient care, direct patient care, patient management, primary care providers, immunizations, write prescriptions, alter the prescriptions as needed, work with physicians, work with groups. So because you're going to see that need and that want for them to do that, I think you're going to see this occur throughout the rest of the country. So.
And I think we've already started licensing APP pharmacists. How many have we licensed now?
As of last week, it was 7.
Wow.
We're having to learn everything the hard way. We're trying to learn these credentialing things and what a residency certificate looks like, because everyone does them differently, and we just want to make sure that we're not too quick to issue a permit. We want to make sure it's actually accurate. So,
But it started.
yeah,
and there
yep,
are
it
now
started. We've
licensed.
got additional applications that they probably have licensed more applicants. I've been out most of the week, so.
I remember last time we spoke that people were clamoring to see who got number 1. Did you decide who that was, or did you just start at a higher number?
We didn't start with 0001 like everyone would have thought we were. No, we didn't want to start a competition or a race like that. The first permit was to the first qualified applicant, the first time it was received, and there was a 20-minute difference between number one and number two in terms of the cashiering numbers. I believe it was Richard Dong Dang was number one, and I think his number is 1255 or something, so.
So you didn't start with number one, though?
No, we didn't want that. We're competitive. We're not that competitive. But we had a lot of interest in that.
Any other board member questions, comments?
I just want to say also that I just appreciate what you've done. I know when I was visiting Louisiana, and I went to a CE, and I remember them mentioning SB 493 in California. So again, I do see that the other states are taking note.
Yeah, well, thank you.
And I also want to just thank you because you've been an advocate for pharmacy in the state legislature and apparently going to continue to do so. So we really do appreciate it.
Perfect, thank you. Well, oh, yes.
Really quick, it's really nice to be here on the board and have you present to me, so I just want to say that.
That's scary, that's scary.
I'm always in the audience watching you, so,
Oh.
but thank you for being here and, again, being for an advocate for the pharmacy, but also for healthcare in general in the state of California, so I just want to thank you for being here.
So I'm sure all of you know, this is my daughter, who is also a mayor of one of the local cities, and she's always calling and complaining about why I can't provide more services to her city. So, but she's doing her job as a public servant, and I'm proud that she's on your board as well. So,
But we really enjoy having her. She's made a really great contributions ongoing.
so with that, I'd like to just close by thanking all of you for allowing me to spend some time with you. Unfortunately, I've got to try to get a flight. My flight was originally sent to go to Burbank. It was canceled. Now I'm going to try to get standby. I'm hoping I get on her flight. If not, I'm here till 9:30 tonight. So anyway, thank you very much for having me this morning.
Thank you, Senator. All right, moving on to the next vendor on our list. I'm trying to find my list here.
Oh, sorry, I'll tell you.
Who is the next person on here, Jenny?
I'm working on it. We took one out of order.
Oh, A Scribe, RX.
ScribeRx offers comprehensive pharmaceutical.
Good morning.
Good morning.
Madam President and board members, Executive Director Harold, thank you so much for putting this board meeting together to, in part, provide some time for these vendors to come and present on the technologies that they have. We understand that we're in between not only people's flights, but lunch, so we'll keep our comments brief. With me today, I have Dr. Reef Gilbum, who's president of ScribeRx, and he's going to talk through the technology that they have that promotes the health and safety of medication dispensing for California residents. We had a PowerPoint that seems to, it was correct.
Oh.
Oh,
Corrupt.
Not saying anything about ScribeRx or Quarles and Brady, but we should have the materials that were provided in advance of the meeting, and we'll go ahead and talk through those slides.
Okay. Thank you. Good morning to the board, and thank you for allowing us to present to you and the board staff as well. I guess I want to do some housekeeping up front so that we can stay consistent and go fast, being cognitive of your time. We are a pharmacy-filled situation where the pharmacist is filling these canisters that are going out. And I'm just building on what I've heard this morning. Also, we are a patient-specific packaging, so this is not a Pyxis style where you open a cabinet and get a first or whatever. What we deliver is patient-specific packaging that has been cleared through the pharmacy process of a PV1, PV2, of course, is this dispensing moment. And the other couple of things I want to get done real quickly is it's key to the understanding of our technology that the canisters that goes in our equipment, the machines itself, the ADDS machine, has a chip technology on the bottom of the canister. So I brought one just to show you that the chip on the bottom is the key element, because from beginning to end, the chip is actually what controls the canister, controls the moment, so to speak. And so once the chip is loaded within the pharmacy, and do you guys have a copy of this presentation at your disposal? You do? Okay. Part of the meeting material?
Right,
Right,
Back.
it's part of the meeting, was part of the meeting materials.
Here.
Okay,
We got it.
yes. Okay, so
Pulling it up from
if we'll go to page 2, that's lists the details of the drug canister, and I'm not going to go through all of them, but basically the important component here is the chip, and the chip identifies itself through the entire system, so it is a closed system. The identity of the drug and everything is, okay, thank you. So, no, this is not the right one. No. Okay. That's all right. So, yeah, I'm sorry, this is not the right. So we'll talk about the canister details again. Once the canister is loaded at the pharmacy by the pharmacy staff, the process is they take a stock bottle, they put the canister first on a chip reader writer, and they scan the information off the stock bottle onto the chip. And this is kind of how the technology starts to produce the error-free system that we know today. And so once the information is loaded into the chip, the person filling the canister, usually a pharmacy tech, will just identify themselves, the pharmacist of record, and the quantity that's going into the canister. From there, a label is printed out, and the label and the stock bottle as a policy, as a procedure, go together, non-affixed to the canister yet. The pharmacist themselves will review the contents, the accuracy of the label as it's printed, and then affix the label, affix the tamper-evident moment, and sign off, both initial and date it. So it's confirmed that way. Then what happens next is these will go into the totes after a manifesting process, which is another scan moment. And so the manifest is then built from scanning this, goes in the tote. The tote is sealed and delivered to the facility as the blister cards are today. Once it gets to the facility, the nurse then will remove the canister. And I'm speaking to other states. This would be I understand nursing is not part of this point, but it'd be pharmacy personnel. We had a pharmacist doing this. We have one operation going in Bakersfield today. And so the pharmacist or the pharmacy tech, pharmacy personnel, would scan this out of the tote into the machine. And so the reason why we use nurses in the other states is because it's very similar to the Cubex, and it's authorized in the other states as such. But it's impossible for the person taking it out of the tote to get it in the wrong place, because again the chip tells the machine what it is. So you can put this canister on one to 240 different locations. And the machine reads the chip. And from that, the dispensing happens, of course, by electronic files that have been cleared. So the prescription that came from the facility to the pharmacy is cleared and goes in an electronic file that is secured I know there was a question earlier about security measures. We've had multiple attempts of hacking into our system. We use a hosting environment that's used by the Fortune 500 companies. It has the firewalls, the protections, it's HIPAA compliant, and we monitor hacks all the time. We can actually see people trying to hack in, and we wall them out. And to this date, after 10 years of operation, I better knock on wood, we've not been hacked yet. So once the electronic file leaves from the pharmacist review of the prescription, and they do all of the pharmacist review of allergies and DURs, that electronic file then goes to the machine, and that machine is then on the ready for dispense. So it is incapable for a nurse or somebody in the field to enter something into our system that would dispense from that machine. And what dispenses is a packet that is patient-specific. And we had a picture of that as well. I think you could see that. So let's just flip pages now. So we've talked about page 3 on canister filling, how you put that on the reader-writer, and it fills the information. We've talked about page 4, the verification process. Page 5 is the labels have all the information on it, from NDC to the quantities, everything about the medication, including scores, color, shape, identified on the packages. For the delivery system we talked about, the canister reception process is what we're going through now. So they would take these canisters out of the tote, they scan them in, and again, this is a scanning process that allows us to do C2s in the other states as well. And we have been vetted by the DEA. The head of the DEA actually got involved with our program because they number every one of the machines according to the DEA rules. But because of what we've done, we've actually had the OIG's office in our office, and we have video monitoring. So these machines are in locked rooms, and then the machines themselves are locked. And we put a special lock on one side of the machine where the C2s go, and we put a special camera on that side of the machine. So the room as a whole has a camera on it, and then the machine and the doors where the C2s has a separate camera on it, all of it video monitored. And anytime somebody opens the door where the C2s are, we have an email or a message that goes to the pharmacist that somebody is in the controlled side of the machine. So it's completely monitored. And so what happens is any user comes into the kiosk, which is in the room with the machine, has to be an authorized user. So we have a whole process around who that is, identity, user codes, access codes. We change those codes on a periodic basis, so we're very much attuned to the security there. And then what happens is in the scanning process I'm talking about, they scan these canisters in, and it is a confirmation that it has made the trip from the pharmacy to the facility. So anything that doesn't show up is set off on alarm. And then once they're scanned in, they'll just put these canisters into the machine, and the machine then takes over on what's there. There's an electronic eye that sits below this canister. So every time a pill is filled into a packet, it's decremented from the quantity. So we have a perpetual inventory that we match up all the time. So if this canister came back and the doses didn't conform to the doses dispensed, it sets off a whole policy and procedure on going to see what's going on. And so when I talk about the OIG, we actually filmed somebody trying to tamper with the machine. And so in our process, we take that information, we process it, we give it to the facility. Most states require this. The Department of Health and the other states that we've been involved with have reviewed our system, been involved with our systems, even asking us to somehow take over certain segments because of the various bottles that are in assisted living and things as such. Is just a.
How does it know the content? Is it weighed, or how does it know that there's something missing?
So in the process of loading, it's counted going in, and that quantity is put into the chip by the person filling the canister. And then as every dispense happens, it goes by an electronic eye, and it decrements that count. So the perpetual inventory is decremented by every dispense. And so the software carries with it the ability to reorder. So it's based on par values. And so none of the nursing staff or the facility personnel get involved with this. It will automatically reorder, and then the return process mirrors the going out process. So as they remove these canisters from the machine, they're scanned in. They cannot go back into the machine and be reused again. Once the scanning out process happens, or even the scanning in process, you cannot access a dispense out of this canister unless you've done that accurately.
So how long, in theory, does each canister sit in the machine? So is, like, what are the turns? So you plan, is that like enough medication to last for a week, a day? So I'm just kind of trying to understand what the volume of drug that's in there.
Yeah, there's actually a lot of engineering that went into that. So what happens is our software will actually look at the dispensed quantities for the past, like, 3-day look back, 10-day look back, even as much as a month. What it's looking for is a change in the admissions or the number of people on this particular medication. And it's basing the par value based on the demand. So it sees the demand hitting the canister. And then we come up to a safety number. To be safe, you're going to have at least 10 in here at the minimum. And so it reorders itself for a 3-day in advanced moment. So if it sees this thing going down to the reorder point, it actually automatically reorders to the pharmacy the canisters needed.
So do you deliver to the facility daily, or what's your goal as far as how often you deliver?
Well, that's a financial decision. So you fill this thing sometimes on the cost of medications, sometimes on the usage, or you may even have some medication availability issues where manufacturing is hard to get that particular pill. And so all those go into consideration as to how the pharmacy, but it's custom configured to the pharmacy's needs.
Who delivers the medication? Does it come from the pharmacy?
It comes from the pharmacy under the delivery service on contract to the pharmacy. So they're usually bonded pharmacy.
And then who places that into the machine?
Here in California, we have pharmacy personnel putting it in. Other states, we use nursing.
You have like a locked, I think Stan brought up a locked box.
Exactly the same as that. They're bigger, but yes, they're secured with one color of a tag that is serialized, and then on return, they're returned with a different color tag that's serialized.
How many installs in California do you have?
We have one.
One.
One in Bakersfield, yes.
Okay. I think one of the advantages that I've seen with these devices is that it allows the nurse to just take out what's active for the patient right before the dose is due, so they can run them every med administration time.
Yeah, well, we discourage that, and only because if there's anything that interrupts the process, and I liken it to the sprinkler system comes on in the building and waters the machine down, shorts it out, then you're dangerously out of medications or unavailable. So we run them every evening for a midnight tonight to midnight tomorrow night, 24 hours ahead. The risk is that we would destroy a pill, which we have a process that's returned to the pharmacy. It's locked inside the machine as well. But the risk is that you may have to destroy 1 or 2 pills because a prescription changed in the meantime. The danger is you would have a complete hallway without pills should disaster happen. And we've had 3 in the matter of 10 years where we had to pull the electronic files back and dispense from a hot backup at the pharmacy. So the pharmacies maintain an exact copy of the machine and inventory and formulary to where we pull back the electronic files, they can then dispense. And a good example would be the disaster recovery plans for these facilities, should there be an earthquake or something, a flood. So we would pull the file back and dispense and deliver to wherever these people were moved to. And it's part of the facility's disaster plan mandate. So that's how we operate there. So when we return these, again, the scanning process is reversed. It goes into the tote going back to the pharmacy. The pharmacy scans them once they're there. There's a whole cleaning process they have to go through before they return back to service again.
They manually count them to adjudicate and reconcile.
Yes. And again, once they're pulled out of the machine, they can't go back in the machine. So in my comment earlier about the OIG, we had a particular person who was trying to get in the system. So because of the electronic eye and because of the chip, we have every piece of information. We know the script, the number of people that have accessed that script, be it a user, the number of dispenses, the time of dispenses, down to our only information lag is the lag of the internet, so it's a fraction of a second. We have video, and so when we discovered somebody was trying to divert, what they were doing was creating multiple PRN dispenses that weren't really a patient in need. We videotaped it. We showed the particular patient they were accessing, the person that was doing it, had the tape and everything, and sent to the facility. And I have to tell you that the OIG's office was in my office 10 days later with all of my packet. And so basically they were there to understand how this worked, because we have sniffers that are attached to this. So we can tell when somebody picks up a canister and puts it down for any reason, at any time, by anybody. And that's in part how we caught that person. So because of that, we've installed this at facilities that had problems with drug diversion, and immediately we've got people who are leaving employment there, and the facilities tell us they know exactly why they're leaving, because they suspected it but couldn't point their finger at them. But the process of finding diversion is very much facilitated. And then as we're getting through the presentation, again, I'm trying to be cognizant of your time. The packets, on the next slide, we show what's on the packet. Again, it's a full description of the medication, so that as they're doing their med pass, they can see color, score, they can turn it over and see what's going on. And the big delta here, if you're comparing us to the blister cards, which is predominantly out there, these nurses are going back and forth between a drawer with a card in it and the MAR. And a lot of times they never even pull the card. They'll lift the card up just high enough to pop a pill out and then go on. And this heads down, heads up is just one of the areas where we fail as healthcare consistency or safety. And that's why I think that when you look at the 8% med errors that are based in the blister card system and why we're so much more accurate, it's because the limitation of human exposure to the process of getting the medication to the patient's mouth. I'm going to move on. The prescription pathways we've pretty much talked through. Again, a lot of these slides are information for you guys to go back and look
I
at.
do have a question, just looking at the label, which is, pretty impressive, but the lot, so you never mix lots in one canister?
We do. On a rare occasion, we'll have 2 lots. We can put in as many as 3 lots. We track all 3, but whatever the expiry date is of the soonest expiration affects the entire canister.
I'm just, on the label, you actually list the lot, so how would you do that? On the label, of the packet to the patient?
Yes, and so if there were multiple, like say they had 3 bottles that had a little bit in them, they could put as many as 3. We'll track all 3 lot numbers.
So it'd say lot number and list all 3 of them, since they don't know
Yes.
exactly? Okay.
Yes.
Thank you.
Yeah, and very rarely do we see more than 1, but we do see 2 every now and then. But
I mean, I can imagine if you're getting back a few, that you don't want to just throw,
well, and so you're bringing up a good point, and I'd like to follow through with here, is because of the lot number and the expiry date, if either one of those are affected, say there's a recall on the lot number, and that lot number was one of the 3, the entire canister shuts down. If this expires in the machine, it shuts down. So there's no way they can dispense from this. Once the expiry date or lot number recall happens, it turns that canister off.
And the pharmacist is reviewing the orders, so the nurse can only remove things that a
That's right.
pharmacist has reviewed already clinically.
Yes.
On the front
Very
end.
important distinction between us and the Pyxis is because I call that non-specific as opposed to specific, if I can get my lips going here. But the issue here is that we can clear the prescription through the internet in a matter of about 3 minutes. And so this affects the e-kit. A lot of things that was normally in the e-kit is now in the machine because the speed of that. It's actually faster to go through the normal prescription clearing process than it is to go get a authorized number from the pharmacy to get into the e-kit. That's almost always by fashion.
The type of facilities that will utilize your product are long-term care,
Long-term
correctional?
care, yes, we're doing, again, this is in various states, but assisted living, skilled nursing, We would like to broaden it, but certainly there's a lot to do right now with just that much.
Okay. And each of your sites DEA registered?
Yes, every one of them.
Okay.
And that came down, Springfield, I guess, is the area of the DEA that controls long-term care. Then issue came up with one of their agents, and it got boiled up to the very top guy, and we wound up with Quarles and Brady's representation having to go through the entire process with the head of the DEA, and his mandate was to turn them on and turn them on quick, because in effect, when you take a look at the med carts, we're reducing the total amount of medications that's available for something to happen with. More importantly, we take C2s and dispense them each day. The state of Texas actually wants to get rid of the control sheet, because if you're only dispensing 24 hours ahead, what do you need the control sheet for? That's their opinion. But in effect, we're taking these lock boxes that are in the med carts that have hundreds of C2s in them. They're counting between shift. And in that same instance where you've got a 30-bed haul on one med cart, we might have 4 doses of a C2 that's sitting in that med cart now, as opposed to the quantity that sits there. All right, so any more questions? And I'll keep going. Again, I'm trying to go fast to get you guys.
How are we doing on timing, Ann? We're at time? Okay.
Okay.
Any questions from the board members?
I just want to ask about the medication packet. You said it's only 3. I'm looking here at the example, and they have 4 different meds in the packet. Is that not true?
It's a customized configuration by the facility. The dangerous drugs, warfarin, as such, we will individualize by just a collaboration between the facility and pharmacy. Other medications, it's better to put the multiple in the packet, because you're handling less drugs and they're right in front of them, and it's very easy for them to do the med to the MAR administration. Even if you have to hold one back, it's still many times safer than a blister card trying to pull 4 cards and get the right cards and do that. So a lot of times I know there's concern about having multiple medications in a packet, but it's actually safer than what's out there today.
Thank you.
Thank you. And I did want to introduce myself for the record, Susan Trujillo with Quarles and Brady. We also have a representative here from the VA.
Yes, my name is Daryl Moore from the California Department of Veteran Affairs, and we currently have 9 of these units operating in the state of California. I'm the headquarters pharmacy services manager for the whole state, and Reeve did an excellent job. One of the other security features I'll just mention right quick, it has a security film that you can wrap across of the canister, and if that film is removed, it has void on there. So I removed it. It shows the word void. Also, one quick thing I wanted to mention to Josh, thanks for clarifying that issue about the nurses, because I didn't see anywhere in the pharmacy board law that it said that a nurse could perform that function. And could you give me the citation that allows the pharmacy technician under camera supervision to do that?
Well, that's only, that's only for license, that's under 1261.6, and it's only where they're using canisters. Let me find it. It's 1261.6 subdivision G, and it describes various requirements for how it has to be done when it's done remotely and then delivered in a secure container.
And if that continues to be the board's interpretation, then, we'd encourage you asked for, areas where, we could use some help. And I respectfully disagree that with that interpretation, I think the facility is permitted to replace those cartridges. But, obviously this is a matter of debate. But this then may be an area where some clarity, additional clarity would be helpful.
Thank you. And just to clarify, you're with the DEA, sir?
No, California
Oh,
Department
VA.
of Veteran
Okay,
Affairs.
sorry.
So
Okay.
for all of the state veteran homes, I'm the pharmacist in
Okay.
charge.
So all of the veterans' homes is where these are installed? The
Under
VA?
a different company,
Oh, different.
not our company.
So it's the similar system. So far, we have 9 up with an expected additional 11 machines we're purchasing.
So it's another company, the same technology or a different?
Same technologies, the
Yeah,
same
we
type.
actually started years ago together and have gone different paths, but we're using exactly the same machine, same technology.
So what's the name of the other technology?
The other technology is called Talus.
Oh,
Remote
Talus.
dis-
Oh, so it is. I was thinking this sounded a lot like Talus, so,
Right.
okay. Perfect, thank you.
Thank you so much.
Thank you
Well,
all.
can I just, to clarify what you're hoping is, I'm just reading what you, allowed placement of the ADDSs without advance board approval. So you want to be able to add them by board vote and not regulation?
Well, what we'd like to do is just plant the seed now that the board has gotten more comfortable or is learning more about the technologies that are available, to think about whether or not there are opportunities for changes in the statutes and regulations to allow these to be placed in other locations. I'm not talking about parking lots, Executive Director Harold.
No,
Yeah.
but we have heard that model proposed, as a matter of fact.
Right, but what we're talking about here today is thinking about things like, a doctor's office that's big enough to sustain a machine like this. They're expensive, so it might be larger group practices, but just to start to think
how
about
would
whether
a-
or not there are
how would a
alternatives
doctor's-
for other locations.
How would a doctor's office use this if the patients would they dispense it to the patient and go home, or what do you envision that happening? Because the patients don't live in the doctor's office, kind of like an SNF.
No, the use of the machine in that situation would be for either a first dose or something, or, an antibiotic that's a 7-day, that's more easily dispensed from the doctor's office. But,
So
again.
it is for take-home dispensing then that you're looking at?
At that point, yeah, the use of that machine would be in that way. But we're just
The
encouraging a
Business and Professions
conversation.
Code allows physicians to have dispensing machines, but it can only be for that specific physician's patients, and the doc, him or herself, has to provide the drug directly to the patient.
Correct. Correct.
So it's
And
very
like I said,
limited.
we're just encouraging conversations that would, expand the use of these machines in more ways.
Thank you.
And I'm asking for Calvet that we clarify who can receive the canisters at a remote location. In this case, I'm requesting that a pharmacy technician can receive this. This has already been reviewed by a pharmacist and is sealed at the remote location, because some of our homes are about 3 or 4 hours away from the central pharmacy.
Yeah.
We'd like to extend that to nursing, because we've already been doing this for 10 years in other states using nursing. We've never lost control of a medication. Our accuracy is never impacted by a nurse or any, the various different people who load the machine. We've never been impacted by that, because it's irregardless of where it goes. And like I said, we've done millions and millions of doses, and we've never lost our control of who has the medications coming back. I mean, we've had several occasions where somebody tried to divert meds, but they're diverting those meds anyway. They just happened to show up in front of our camera, and we caught them. So I think it's a safer environment. It may be a great way to help the facilities isolate those people, because after I got through talking to the OIG's office, they identified that long-term care was number 2 to the meth labs in the United States for drug issues.
Yeah.
So I was shocked to hear that, and so they wanted them to take us into their problem facilities. So I don't think that we were built to be the police to this, but it does add that much security.
Thank you.
Thank you.
Next, we have Omnicell.
Let's go.
Good afternoon. My name is Bill McGuire. I'm in charge of the regulatory affairs for Omnicell. And with me is Rich Hooper, who's the National Sales Director. Today, I'm going to describe pretty much the 3 deliverables that you'd asked for as far as pharmacy goes. You wanted to advise how our cabinets keep consumers safe, basically what kind of laws are impeding the use of ADDs, and just a little bit of a summary slide. So what I'd like to do is go right into it, try to keep this in the 10 to 15 minute. There's a lot on here. The first 8 are going to be covered in the next slides, which will go relatively quick. But for example, the Omnicell, the system itself is all steel cabinet. So it takes a crowbar and a hammer and probably a jackhammer to open the machine. We're going to talk about the safety, the restocking with barcoding. And that's very detailed with the barcoding. We go down to the NDC specific level. So it covers the Drug Supply Chain Security Act as far as crib to cradle. I want to point that out in a few minutes. The safety stock is something that's unique for us. These cabinets are being used in primary long-term care facilities, and pharmacies packaging it, unit dosing it, putting it in cards, putting it in a pedigree tamper-evident container. And when it gets to the long-term care facility, the safety stock is going to help guide that person restocking the machine. We also have a biometric. You heard about that several times as far as a finger scan. One of the things we do allow, we have from our database from the pharmacy, is called tall man lettering. For folks that may not be familiar with that, it just helps prevent medication errors both in the pharmacy and the nursing practice. The look-alike, sound-alike drugs. We allow that through the database. The other thing is patient allergies show up on the screen. So our system is truly profiled just like in an acute care setting. An order's entered, it crosses over, it shows up on the screen, and any allergies that are on there, there's a second check with nursing, they can see that allergy. So it's, you asked for consumer protection, we think we added some things in here. Again, the real-time interface, if in fact there is an override on a first dose or an emergent, that's taken care of at the cabinet, but the allergies still show up for the patient, okay? Most facilities that are 24/7, those first dose and e-kits are actually either on-call pharmacists are going to enter it in, and the larger facilities, they're going to enter in that order anyways, and it's going to be profiled. So there's a lot of cross-pollination, if you will, as far as real-time information for that cabinet.
And so your cabinet's really more for the first fill, and then once again, after the first fill, the prescription comes. And when I look at the drawers on the page 9, so it's like a lot of drug, and so they would, I know just that one little cubby hole will open up, and so the thought is that they would take the one dose.
With a barcode scanning.
Okay. But what if they took one dose of the OxyContin barcode scan and then like took a couple other over here?
There are two ways to work with that. First of all, there's a witness program you can use to restock it, okay, a nurse witness, we call it. The other thing is a blind count process. And the third thing is really, there's actually a tray here we didn't show you. It's actually a unit dose tray. It would only have one in it. You could actually get down to that level if you wanted to with one in it. You have a drawer of, I think, 96 unit dosed, one to a bin. Okay?
Thank you.
Let's see here. Alarm system. So if someone tries to get into these drawers or the bins, once you've opened the drawer, it has a real-time alarm on that. And it also sends an electronic message to wherever I want, either the director of nursing, director of pharmacy, depending on how you want it set up. It'll notify me if someone's trying to access a drawer or bin without authorization. Okay, and that's called a null transaction, which also shows up in a report that we'll talk about a little later. Okay. We talked about NDCs a little bit. The NDC is the kind of nomenclature for a drug. It really ties it from when it's manufactured, who manufactured it, what size and bulk. And with the new law, pedigree law, it's important that we follow that for a couple of reasons. For consumer protection, it prevents Medicare fraud. We're billing it correctly. They're getting the right drug. Okay. We also know where it's gone. The other piece is, as of 1/1/2017, they're called J codes from Medicare Part B. That's just a Medicare billing piece. But now they're requiring waste. And there is a certain subset of non-acute patients that do need Medicare, that have Medicare Part B drugs billed. So those are things that we're actually helping with Medicare fraud as far as making sure that they're billed correctly, because the rebates come back to the government from drug manufacturers. You've got to bill it correctly. A thing that was talked about is external return bin. Again, it doesn't go back into the machine, it goes back into an external return bin that's only emptied by pharmacy. So if you take out 2 Percocet and you find the pain scale is only down to 1, or 3, and you only need 1 tablet, you can return it, but you're not returning it to the actual machine. You're able to return it to an external return bin that's metal locked and only keyed by pharmacy. And we'll talk a little bit about the reporting and some of the ISP guidelines. And ISMP is really Institute Safe Medication Practice, and acute care has heard that a lot. It's starting to come to the non-acute, if you will, as far as practices, best practices, and they're actually redoing the guidelines as we speak. So just real quickly, the cabinets, we talked about the barcoding, we talked about the external return bin. Those are the lights on the drawers. So that's the guiding light. So that's how I know when I'm stocking it, I'm restocking it, I know what drawer to go into. And then it goes into, and it will go into the actual bin. The reason I show you these is because some of the places we're going to recommend and ask about takes a smaller machine for patient safety, like the quarter height cell or the half height, where some of those places we're going to talk about in a few minutes. So there's the restocking with barcoding. That's also pulled, when they pull a med out, a nurse pulls a med out, they also barcode scan it. So you know what's going in and what's going out every time because it's barcoded. It's not just pulled out. And you have a question? I don't know if you had a question.
Restock?
No, I'm good. I'm realizing that there's some larger items, and that's why.
Oh, those are just examples. Basically, they're all closed matrix for the controlled substances. In California, I was advised to make sure we had closed matrix for everything. That was a suggestion we had from the DPH and Board of Pharmacy that we're recommending. This piece here is just the lid technology that we talked about, where the lights come on, so you can guide you right to the exact bin. Some of the drawer configurations, and to your point, there's a unit dose drawer that I should have put on here, but didn't, so for future reference.
Well, and I guess what I was looking at is in the picture of like the big unit, there's like areas where, you know, they're big, and those are just bigger items, but it still is the same theory. You can't
Correct.
get into
Correct.
those slots. The little light comes on
Separated.
and you can only get into that slot.
Correct. So if you think about the bigger bins, let's go back up there real quick. So the bigger bins, you may have IV fluids that they may have to hang. But what it does, it opens that section. There may be 5 bags there, but the light takes you to the correct product. They're not controlled substances per se, but they're like IV fluids, or there may be a bulk mucomagnesia or something that they may need that they can't repackage any smaller than that. But it still guides you to the correct one. One of the other things we talked about briefly was just the reporting process, and you're asking, well, how do you know by reports what's happening? We talked about the null transaction. The null transaction is where someone's trying to attempt to get in there. We have examples of this on the attachment. Discrepancy reports. If you put it in there and it comes up with, you say they take 2 instead of 1. We're going to find that out when they do when it's actually done as adjudication, end of month adjudication. Blind count will tell you right away if there's something missing, if something gone. You also can use a nurse witness to restock. You can use 2 people. And if you use a nurse to verify it with the technician, or depending on what setting it is, you can have 2 people verify that you're restocking it correctly. Okay. There's barcoding. Barcoding shows if I barcode it wrong, I need to train that person better onto stocking, because they're barcoding it incorrectly, it will not stock it. Okay. It comes up and it flashes, it generates a report. Return, and then dispensing practice. That basically looks at who's standard deviation. 2 standard deviation reports are looking at as far as what's being taken out. If Rich and I are continually taking out Percocet on a regular basis, but you take it out maybe once a day for that same patient, there's a standard deviation being brought. So reviewing of these reports are critical, no matter what setting it is, acute care, non-acute. These are the ISMP guidelines, and by the way, those are some of the standards for best practice that they use around the country. They are being redone, but these are the standard that we use, and probably most folks do, as far as what's safe for the patient. What areas of law that we think that we could need some help on? You already answered the nurse restock piece as far as clarity with that. PACE, that's a big, long word. If people don't know what it is, I'll read it. Programs of All-Inclusive Care for the Elderly. It's a Medicare-based reimbursement, and it's a group medical process where the patient comes in and they treat them as with all pharmacy, physicians, nursing, rehab. It's federally funded. Then the assisted living facilities are also places we think these half-height, these smaller machines could be. Because if they're coming in and they're there for the day, adult daycare, if you will, and there's something that happens, wouldn't you want to be able to access something and have it accountable? So we're thinking we don't have a roadmap, and we'd just like some clarity. If there's a roadmap, if there's something we could do to be able to put them in there, we think it's safer. Okay. Freestanding emergency departments. You may not have them in California. I'm not even sure. But I will tell you that there's 300 to 400 of them existing now, and they're growing very, very fast. And not all of them are connected to IDNs. So we need to have clarity on the standalone free, if you're going to have legislation, you may want to start thinking about it, because those require controlled substances. If you're going to actually take care of heart attacks and strokes, you're going to need those medications, just like you would in a regular emergency department. And then the ambulatory settings, infusion care, doc in the boxes, anything that would cause you to have medication, or asking for just a roadmap of understanding what we want to do it right. So like with nurse restock, we were told we couldn't do that. We have not done that. We've told our customers that. We want to make sure that we follow what you tell us what to do. So yes, I'm sorry, EMS. That was the other piece that was brought up earlier. We actually have a very large customer in this state that we had to cancel the contract because there was no roadmap. They said that their legal counsel said that there wasn't anything they could do right now with this. And we have an EMT on our staff, and he just said, besides a locker with just people checking in and out stuff, it really makes sense to have accountability, not just for controls, but for everything. You want to make sure that there's some tracking record. So if we could, and I think Ms. Harold mentioned that there's some legislation working on that. So we just appreciate, tell us what to do, and we'd like to follow it.
You have units currently in California?
Yes, we
Yes.
do.
Approximately, we've asked others, approximately
Sure.
how many?
Sure. So in the state of California, we have several hundred hospitals that have Omnicell as their ADS facilities. There's about 75 skilled nursing facilities that have our ADSs in there, ADCs. And we've been limited because of our customers. So our customer is not the skilled nursing facility. This customer is the institutional pharmacy providing pharmacy services to those skilled nursing facilities. So when we reach out to our customer base in the skilled nursing base of institutional pharmacies, we work with them. And since we've been presenting here at the board since about 2012, late 2012, we've been discussing the point of restocking. Obviously, it would be in the best interest of a vendor or an institutional pharmacy to have nurse restock. It would be easier for them to send the meds there and let the nurse restock. But we were working on the reg with the board and in the interpretation of it around tech restock. And we've been following that since January, tech restock, but before that, it was pharmacy restock. So we've been above board really working with the board on that. But it's limited us, as we've approached our customers, to only have 75 skilled nursing facilities out there, because they've asked us, what's your interpretation of the reg? And we tell them, tech restock, period. Now, and it was pharmacist restock. And so we were basically told to pound sand because they were saying, well, we're going to do nurse restock. And we were trying to do exactly what the board tells us, and we're on the minutes here talking to the board several times. So thank you for the clarification today on that.
Any other questions, comments, concerns? Thank you for your time. I appreciate it.
Thank you very much.
Move on to, the next one on the list is Steris.
Yeah, it's actually good afternoon. Well, my name is Mark Curry. I'm with the STERIS, Vice President of STERIS. I've been clocked at 250 words a minute with Gus up to 500, so if I get talking too fast, let me know. But anyway, I'm going to make this quick because we've appeared before this board since 2009 on repetitive times. We are the company that's going through the study currently being undertaken, actually finished at UCSD, and the results are going to be delivered to the Enforcement Committee prior to their meeting in April, so they'll have time to review the study. And those information is being provided by Dr. Jan Hirsch from UCSD School of Pharmacy. I'm going to make it very simple for all of you because, again, as I said, we've been here so many times that I'm looking where she put my presentation. That's not it.
Find the board website.
She's coming? Yeah, she set this up for me. That's all right. No worries. Oh, she brought food, more important than this.
the Steris, which is number 6.
Anyway, while she's doing that, I just want to say that basically, this is a filled, finished prescription product, which means it is completely done, and the prescriptions are filled by a licensed pharmacist. We don't impact that process whatsoever. We are a product that provides delivery of that finished prescription to the employee of the hospital, to the patient, through discharge, et cetera, et cetera. The technology is actually has the capability of being held so that no prescription is delivered prior to consultation, so that consultation occurs on every new prescription that's provided. And what we thought we'd do is put a 5-minute little video together for you so you can watch it and see it. And if there's any questions after that, I'll be on my way.
Hi, I'm Sarah Lake, the Director of Communications and Regulatory Affairs here at Asteris. I'm going to show you a little bit about ScriptCenter for 24/7 prescription and OTC pickup. ScriptCenter is used for patient-specific, finished prescriptions that have already been verified by the pharmacist. Let's get started, and I'm going to show you a little bit about how that works. I'm going to log in to ScriptCenter using my fingerprint and PIN or an ID and a PIN. Today, I'm a patient here picking up these 2 prescriptions. I'd like to point out the one prescription here in red. This prescription requires counseling, or the pharmacist has put it on hold because they want to speak with me for one reason or another. I may not pick up this prescription until I have spoken with the pharmacist. I would have received a text message or email notification instructing me to contact the pharmacy before I can pick up this prescription. All required counseling occurs on prescriptions before they are picked up from ScriptCenter. Today, I'm going to continue on with my one prescription pickup. I will sign here on the screen, and ScriptCenter also takes a photo of me. I will pay here for my prescription with a credit card, debit card, FSA, or payroll deduction if that's something that the facility offers. ScriptCenter takes a photo and a signature, which is kept on file. And we'll talk a little bit more about that in a moment. Out of 16,000 people surveyed at ScriptCenter, more than 96% of them say that they'd recommend ScriptCenter to a friend or colleague. More than half of patients say that ScriptCenter is a key reason to use a particular pharmacy. You can see I now have my prescription and I'm on my way. Let's take a moment to talk a little bit more about how this prescription got into ScriptCenter. Let me show a video of what happens on the pharmacy side. Remember, prescriptions are filled as usual, and you can see that here. The prescription's been filled, verified by the pharmacy, and the pharmacist is now putting it into the container. They scan the prescription and then scan the container. ScriptCenter comes with one of 3 different size containers, a small, a medium, and a large. The pharmacy staff member then securely transports the prescriptions to ScriptCenter to be loaded. ScriptCenter can be loaded from the front or the back. Here, you see the pharmacy staff member accessing ScriptCenter from the back using his fingerprint. He now loads the prescriptions into ScriptCenter. Prescriptions do not need to be located or loaded into a specific slot. ScriptCenter's sophisticated barcode technology takes care of locating any necessary prescription. Any prescription that has been expired or needs to be returned to stock is automatically moved to what we call the unload tray. Let me point out a couple of additional security features. One is what we call ID Verify. Prescriptions that require ID verification will instruct you to put your ID onto the tray on ScriptCenter. A pharmacy staff member then must verify identity before releasing the prescription for pickup. This is especially important for controlled substances or any item that requires ID verification. Next, I'd like to point out our photo capture reporting. We talked about this earlier. Script Center captures a photo and a signature for every pickup. This is one of just a multitude of reporting features and functionality that Script Center offers to make sure all prescriptions are tracked at all times. Lastly, Script Center is also equipped with what we call our locker columns. This enables large or bulky items to be picked up from Script Center. Let me show you some examples of where Script Center is located. Here you can see a small sample of some Script Center implementations. Script Center may be used in hospital facilities for employees or those working second and third shifts that maybe don't have access to the pharmacy while it's open, or potentially discharged patients leaving the hospital to go home. This enables them to have better access to their prescriptions, quickly and conveniently pick them up 24/7. Script Center has delivered over 1.5 million prescriptions. We here at Asteris strongly believe that increased access to prescriptions leads to improved patient and prescription adherence. Thank you for joining me today and giving me the opportunity to show you a little bit more about Script Center. Thank you.
That kind of puts a visual behind what we do and what we've been doing now for quite some time. Are there any questions from the board?
So for the most part, are your machines are like in the case of, down at UCSD, basically on a campus. And I think years ago when you came in, they were sometimes going to be like in the front of a store after the pharmacy closed. So you're always thinking it's going to be within the building, maybe not within the license area, but within the building of the license?
That's what we're looking for exactly, is extension of 1713 so that we can put that technology not 20 feet from the dispensing pharmacy, but possibly up in the lobby of the hospital where it's more convenient for the employees and their dependents to pick up their prescriptions. We're also looking to request for worksite locations. We have a lot of hospitals that have large executive offices that may be off-site away from the licensed facility that would like to provide those kind of services for their employees, but that would be up for the board to determine. But at this point in time, we're looking for all medications to be delivered in the covered entity, but not limited to 20 feet from the dispensing pharmacy. By the way, we also have OSHPD to think about in California as well, and we do have OSHPD-approved bolts that go into the 1,300-pound beast as it is, so nobody can take it away.
Questions, board members? Victor?
Yes.
So if you couldn't hear, I'm not sure for webcasting, the question was, is it fire resistant? And your answer is?
Yes.
All right. I think, thank you very much.
Thank you.
And should we go ahead and break for lunch? Let's see, it's 12:24. Do we want to reconvene at 1? Because it's a little over a half hour. All right, thank you.
Majority of those are in Illinois because, again, Illinois is the most expansive regulatory environment, but 15.
Thank you.
Okay, any other board member questions? Right.
There's a possibility that the video would work now. If you're interested in seeing how it interfaces. No, it's not up yet. Okay. Well.
Is your link, is it on YouTube or?
Yeah, she has it on a hard drive and.
Do you have it set up, Debbie, so we can watch it?
Okay,
Okay.
great.
Welcome to the MediVale Med Center and to fast and convenient medication dispensing. It's as easy as 1, 2, 3. 1. Send your information to the pharmacy. 2. Get a personal consultation with the pharmacist. And 3. Pay for and pick up your medication. It's safe, secure, and it takes only minutes. Just touch the Start button to see a menu of choices allowing you to fill or refill a prescription medication. By following the on-screen instructions and using the devices on the Med Center, you can securely capture and send your prescription, identification, and insurance information to the pharmacy. If you have questions and wish to contact the pharmacy, you can touch the Assistance button at any time. Once you've completed the first step, you will be connected by video call to the pharmacist. He will be able to see the information you've sent and will give you a personal consultation about your medication. For a more private consultation, just pick up the handset and talk to the pharmacist. Inside the Med Center, your medication is being prepared and labeled for the pharmacist to verify. Once your medication is ready, the pharmacist will ensure you have no further questions and the video call is ended. The final step is payment, which can be done by credit or debit card. Simply provide payment and the door will open for you to collect your medication, drug information, and payment receipt. That is how safe, easy, and convenient it is for you to use the MediVale Med Center. Let's get started. 1, 2, 3.
So that video kind of shows how it interfaces with the patient in terms of the connection with the pharmacy. There are some slides here that show the stocking drawer. If you had any concerns or further questions about stocking the dispenser, it's fully automated, and unlike some other technology out there that relies on barcode technology solely to verify. In addition to that, the Med Center has got cameras inside the machine, so the pharmacist who's doing the final check can actually see the label that's going to be affixed to the bottle. Can't see the inside contents of the bottle, but can see the medication, the medication name and a final safety check to be sure everything is correct before it gets dispensed.
What if somebody enters a prescription for something that isn't in the machine?
Yeah. That's a good question. One of the things about this technology, again, is that it's never going to replace a pharmacy. It's meant to supplement pharmacy services, and you need to be really kind of careful about working with the prescribers in an ER setting, for example, or at a clinic to set the formulary. Seema could probably speak to the number of different drugs or line items you can put in the machine, but it's a pretty big vault, pretty good capacity, and if you set the formulary correctly, hopefully you wouldn't have those issues. If you do, it would be just like any other pharmacy where you could transfer a prescription or return the prescription to the patient so they can get it at the pharmacy of their choice.
I had seen or witnessed another product that was similar to this, and they had used proprietary bottles. Are you doing the same thing, or can you put any type of bottle in there?
You can put any kind of bottle in it. You can use a manufacturer's bottle if the label will fit on it, because certainly you can't cut with scissors and apply it. It's done by the machine.
Got it. Okay. And it can do multiple languages just like a pharmacy does?
It can. We're still working on some of that technology in terms of either getting the information on the label or in a supplemental sheet that could be dispensed through that dispense drawer.
So one of the things we may want to, the board may want to look at when we consider this is a language capability too, especially when there's labeling that's actually being placed, because there are some state laws right now in California that require translation.
So so there is a proprietary, I won't say integration, but between the pharmacy system and the label that actually prints. So whatever prints on that pharmacy management system will be translated. Will print verbatim on our label. So
even if it's another language?
If they print it in Spanish, it will print in Spanish on our label.
Okay.
It'll be a
So you're just a printer, essentially, to the pharmacy system. So then you shouldn't have a problem.
Yes, that's correct.
And so, kind of going to what Amy's question was about the bottles. So are they, for the most part, manufacturer, or are they more stock-sized bottles? And if one patient gets 21 pills and the next one gets 14, you give the 21 or 14, or are they like pre-packed? They're preloaded?
That's right. The pharmacy the personnel at the servicing pharmacy If the manufacturer's bottle is not appropriate, they can use these, these bottles that are all the similar size. So, those are what we recommend. But if the manufacturer's bottle meets the specification of the label, they can use that.
And I guess I was thinking more about the quantity. So if it's coming kind of in a pre-packed 30, but the physician, for whatever reason, orders 21, and that might go to your point about the formulary, that you kind of tell them, this is what we have, and this is what you order, so that's,
Yeah.
is that kind of the way you direct it?
Well,
I think what you're getting at is a situation where you don't want a situation, I know this has been discussed even among this board, you don't want the prescriber to start prescribing to what's in the machine and changing your prescribing patterns to meet what's in the machine. That's not what occurs here. If we can't dispense a quantity that the doctor prescribed, it would be just as in a retail pharmacy, if you're out of stock, you'd return the prescription to the patient and have the patient go elsewhere. If it's a situation where you have a stock bottle of 21 and the doctor prescribes 30, potentially there could be a conversation with the patient and with the doctor to do a partial dispense and then arrange for delivery or pickup of the remaining quantity. But it would never be a situation where you'd change or alter the quantities just to accommodate a patient without obviously keeping the doctor in the loop.
But so they're all pre-packed?
Prepackaged,
And
yeah.
you're not changing the quantity from the pre-pack?
Correct.
And do you do like creams and liquids, or is it all?
That's correct. Creams, liquids, oral contraceptives.
Okay.
It's whatever that particular location utilizes and dispenses.
I guess one of the questions that sometimes comes up with boards is what about reconstituted medications? And different boards have taken different approaches to that. Some boards have said, well, that you can't have a patient adding the water to the amoxicillin suspension. That's compounding. So unfortunately, in some states, you can't do meds that require reconstitution. But in states that are more receptive to it, if you provide the pre-measured water along with the amoxicillin powder with instructions to tell the patient to bang the amoxicillin, loosen the powder, add the water, and shake it. Some states were comfortable with that. So it would really depend on what this board is comfortable with in that regard. We've been through this type of presentation before many boards around the country. We've actually presented before this board too, not with a potential deployment partner, but just a informational presentation about a year or so ago, maybe a year and a half ago. But it's technology that I think is, and we all think it's exciting technology in terms of being able to bring pharmacy services to the point of care.
Thank you.
Thank you.
Okay, and I want to thank Scarlett Eckert too for allowing me to go first so I can catch the flight. Thank you so much.
Thank you. All right, you've patiently waited.
You traded spots.
I'm
That's
collecting
even more.
later. So on your list there, I'm from Arxium. It says I'm Tom Burns, but obviously I'm not Tom Burns.
What company are you from?
Arxium,
Arxium.
Arxium.
That's how you say it, Arxium.
Yeah.
Okay.
Believe me,
and
I said it wrong for the first year. Arxium.
And what was your name?
Scarlett Eckert,
Scarlett.
Eckert. I am a pharmacist here in California. I'm the brought mine up just in case it was gone, because I can't talk without the slides. I wouldn't know what I was saying. So our system is designed like a vending machine. So we don't do priority vials. We can do anybody's vial as long as, like you said, the label fits. We do standard dose quantities in the vials. And to your question of what happens if the prescription is different, when the pharmacist is verifying it, they would ask then, do you want me to dispense this part of it today? And then you either come pick up the balance of your prescription or we deliver the balance of your prescription to you. So, do I just hit that? Where'd she go? Do I hit the down button to make this go? Oh, there you are. Sorry. Yeah, okay. We use biometric sensor to do fingerprint ID to get in and out. We have password option also available. And then the access levels are determined by the administrator when they allow the person in. So some people may be only able to dispense certain products, others could dispense controlled substances, some people can print reports. They have control over that. And I'll show you the reports in a minute, but we have access reports, we have transaction reports, inventory reports. There's many different types of reports. I feel bad because you guys are all leaning around trying to see this. And it collects all the data. The narcotics are secure, and it can be done with a blind count also. One container is dispensed at a time, and like a vending machine, it goes down into a bottom compartment that you slide your hand into. You can't get your hand up there to get anything else out, so it's only that one product that comes out. It's a triple check barcoding system. The bottle scanned, the label scanned, and the patient's information is scanned on the facility's information system. All of it has to, in order for it to be released, all of it has to have been seen by a pharmacist. They see both the scanned prescription, the patient's information, they check all the records, look for all the interactions, any possible problems, right quantity, right drug for the diagnosis, and it has to be released before the end user can actually access the patient's system to get to the prescription and get the bottle to come out of, or cream, or inhaler, out of the machine. This is one of many configurations. It can be a single door. The door does not open. That's only for when loading. I just wanted you to see that it's a vending machine style. Or it can be designed with 2 different compartments. You can have a third module. You can just have a small one. Yes?
Open.
No, the door's open there. Is that what you're seeing? I just wanted...
From an angle here.
Oh, yeah, sorry. I just wanted you to be able to see that it's like a vending machine. So it's a coil that spins so the product drops out. And then it goes down, which you can't see very well from where you're sitting, into that blue drawer at the bottom, and that's the access panel to put your hand inside and pull out what's been released. There is a label printer that prints. The label information comes from the hospital, or not the hospital, so I work mostly in hospitals, the pharmacy's information system. So if they type in Spanish, it prints in Spanish. But the information comes across from them and pulls also out of the ADD the information of the bottle itself, so they know exactly the unique lot number, unique ID number, lot number, expiration date. Yes? They are freestanding. They can be bolted to they're heavy.
Not on rollers, right?
They're not on rollers. Those are legs.
So
We just roll them around wherever we want.
How does the consumer see this? I mean, is there, like, where's the welcome, or is there like
It's not
a
for the
technician that's pulling out the...
It's
or-
not for the consumer to walk up to. These are designed to go into like clinics,
Okay.
possibly physicians' offices. That's one of the things
So
we'd
the
like to see.
physician or the...
A healthcare provider would provide the medication.
But it prints a label.
But it prints a label with all the patient information on it and the product information to be able to take that home.
So it's like as if someone in the clinic would walk over to the pharmacy and pick up the completed script, but
Yes.
now it's just available to them.
With the caveat that the label comes out separate and they have to barcode scan all 3 pieces to have it say, yes, put the label on the bottle.
You're having non-pharmacy staff labeling a bottle.
Wait, say that again. So the bottle comes out, the label comes
The
out.
bottle's
Has to put it
labeled,
together.
the bottle's labeled with product information and a barcode, but the label prints out separate from the bottle. It doesn't label it inside the machine.
Someone in the clinic has to put all those together.
Why did you do that? I mean,
I didn't design this.
It's just,
I work with
she's just
engineers,
giving us
please.
a summary.
I ask the same questions all the time.
Yeah, because that seems like there's
A disconnect.
So would it only allow one medication at a time?
Yes.
But if someone was, I mean, I could see me being efficient and saying, okay, let me just get all these 3, boom, 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 boom.
Can't. Until you verified the bottle, the label, and the patient information, you can't pull the next product
But it
out.
doesn't know if I put the label on.
It doesn't know if you put the label on.
Are you installed in California?
We have 3 sites in California. I had to ask this when you were asking those questions earlier. I was like, I don't know. We have, where did I put it? Chula Vista, somewhere in San Diego, and Reseda.
And are you in physicians' offices or?
They're in clinics. or what someone told me was clinic, now that I'm wondering. I
Like,
don't know if they actually
state
found out they
board-
were
State board
licensed.
pharmacy license clinics?
Sorry, I really can't answer that. I can find out for you, though. We're in 16 states, so 15 other states. So the bottle's always labeled with the product information, the NDC number, the quantity in the container. It has a unique identifier for each individual bottle, so you can trace it back to who filled it and which patient got which bottle. We already talked about triple check barcode scanning. Everything's, like I said, pharmacy reviewed before it's released. There is a consulting.
Actually, just how does the pharmacist review it before?
Reviews the prescription and activates which product will be released for that prescription.
Like, you know how the other ones have like this visual thing?
No, it's not real good with it. It's like a Pyxis machine or an Omnicell machine. Each section is identified for which product. So when you enter the information for that product, it pulls up that's the cue, like this microphone, not that microphone will release. It has a two-way audio and video system for consulting, or they can do a Skype or just a phone call consult if they're not comfortable standing in front of the machine. Never, no.
When you had the prior slide up with the picture of the machine, I tried to envision where the audio-visual communicate.
It's not on there.
It's just not on that.
There's a thing that stands next to it that's a console.
Oh, I
with
see
the
that
video.
fits.
Yeah.
Okay, thank you. Yeah, because
I
I couldn't
apologize.
envision how that would work. Okay.
No, there's a console that sits next to it.
Is the pharmacy restocking it?
The pharmacy is restocking it. In California right now, it's a pharmacist. Those are at the end of my slide. That's what we'd like to talk about, the impediments, if the technician could do that.
The pharmacy is stocking pharmacy stock in here.
The pharmacist is stocking the stock in there. And it's barcode scanned in, it's barcode scanned when it comes out. Everything's recorded. Whoever goes in and out of the machine records it. Any transaction, the information, this is just an inventory sheet. This is just a user access sheet. And then this is like a transaction sheet. It tells exactly, you can't see, obviously, the patient's name and stuff and the prescriber. But it pulls all the product information, the patient information, the doctor, the time and date, the prescription number, the NDC number, the lot, the expiration date, and the quantity that was dispensed. So the impediments that we were hoping to talk about were, because these are bulk bottles, essentially, they're not unit of use. To move to be allowed, for the technicians to be allowed to stock or an intern to be allowed to stock, if they were tamper evident or shrink wrap sealed so that you would know if the bottle had been tampered with at all.
What do you mean by bulk bottles? Do they
They're-
walk in
They're like dispensing bottles out of a retail pharmacy. They're not unit of use packaging.
like a bottle of 500 tablets?
Oh, no. A bottle of 30, a bottle of 7. Like a prescription bottle you get when you go to Long's or, well.
Oh,
Long's
so it's
is-
it's actually an amber vial?
It can be. Yes.
The pharmacy's putting it into a vial, but they don't put a patient name on it. So it has some kind of barcode identifying what drug is in there.
And it has a labeling of just like a product to go out dispensed as if it was came from a manufacturer of
So it
30
had like
tablets.
the drug name, the lot,
Mhm.
the
Expiration date, lot,
barcode.
NDC number, unique identifier, a barcode on it.
And so then the technician will bring these to the pharmacist.
Right now it's
will
the
bring it to the
pharmacist.
machine from their stock.
Yes.
Place it in there, and then when that vial, when that medication's needed, then that will come out again with the label printed out, and then someone at the clinic needs to.
Barcode scan all 3 pieces and then attach the label to it. So, but in order for a technician, the way our law reads in California, because in other states, the technicians load the machines, we would have to make sure that we were putting some kind of tamper evidence seal across these, just like a box that has cream in it. You would want to make sure that you had a tamper evidence seal on it, so you would know that nobody had tampered with that product before it was released to the patient. So when the pharmacist signs off that it's transported with ability to know that it was a clean product when it came out for the patient.
But currently there is a temper evidence seal on it right now.
What I'm saying, no, I'm saying if you would add if you were to add that a technician or a resident or intern could be stocking this, because it's not a pharmacist stocking it, then I would think that it would be best to add into the language of the law that it had to have a tamper evident seal on.
You
the
have
bottle.
tamper evidence seals?
We do,
Okay.
yeah.
Are you doing controlled substances?
Yes. I don't know if they're doing them in California. I know they do them in other states.
So if I'm a pharmacist and I'm restocking it, and I started out with 30 controlled, and somewhere along the way, 20 got put in there, because I pocketed 10, how would you detect that?
So the bottle has 30 in it?
The pharmacy's restocking, right? They're packaging. So it's the bottle, the label says 30, and the pharmacist put 30 in there. But somewhere between the pharmacy and the machine, someone took out 10.
The tamper evidence seal would be gone, and you would know that the bottle had been tampered with.
So it's just like is it a
Well, it depends. Sometimes they're shrink wrap. Do you know what shrink wrap is? And then, the tamper, like a
sticker?
Like a sticker, but it's, the metal kind of that goes over. Those are used too. So if they're broken, you know that the bottle's
But the
been
machine,
tampered.
so if, just kind of following Amy's process here, so the machine wouldn't stop it from being, like, the machine wouldn't detect that it's been,
The machine won't detect that the bottle's been
it
open.
won't detect that the seal's been broken or the bottle's too light.
It's the pharmacist who's stocking it that's supposed to look and see whether the tamper seal's broken.
Well, right now, it's the pharmacist that's transporting the product over from the pharmacy, so.
So are they transferring the ownership over to the clinic on a DEA form?
Well, that's, right now, all of them belong to the pharmacies. I don't work in the pharmacy, so we provide the equipment. Right now, the pharmacies that are using this, they own the machines.
So they're transporting their controlled substance into another location? Okay. I'm a little concerned about this as the way it is, from what it is now. I'm looking at our attorneys. Is this legal right now for for a pharmacy to store controlled substances in a location that is not on their physical pharmacy license?
I mean, I don't know that we want to be opining at open meetings on possible enforcement matters
Okay.
with regard to a particular
Got it. Thank you.
location.
I'll have to ask the pharmacies, because
Okay.
we just provide the equipment. We don't actually provide the
Okay.
pharmacy service.
Got it.
So that's one of the impediments that they've talked about. The other impediment is the monthly inspections. If the physical monthly inspection could be done by a technician and the quarterly review still be done by a pharmacist, that would help out greatly, because that's a lot of pharmacists' time to go out there. And technicians, I will tell you, probably do a much better job than most
Asking
pharmacists.
for pharmacy techs to do inspections?
To do the physical inspection of the machine
And restocking?
and the restocking. But the quarterly, obviously, clinical inspection and review would always still be done by the pharmacist. And the last one was if we could get clarification on 4186F, where it says that the pharmacist operating the automated delivery system shall be located in California. For any of the loading and unloading, obviously, the pharmacist overseeing that process would need to be located in California. But we'd love clarification on the fact that order verification can be done by a licensed pharmacist, California pharmacist, but not having to be located in California. Lots of hospitals, I did at UCSF when I was the director there, that we had order verification done and they weren't located in California. So they sometimes weren't located in the US, but they were licensed in California. That's so. It was just
The
more
machines were
clarification.
licensed?
No. The pharmacists doing
Pharmacists.
order verification weren't actually physically in California, but they're licensed in California.
Got it.
But they did order verification. So it's just more clarification on the language, because the company that does have these machines, the three down in
Is that currently, counsel, is that currently a limitation of our statute? Is that the person who's verifying the prescription has to be in California?
No, as far as I know, that's not a limitation.
Okay.
But the way this reads, they read it that overseeing the, that pharmacist operating the automated dispensing delivery system shall be located in California. They read that as they couldn't
Oh,
have.
I see, 4186.
Yeah, they
I see.
couldn't have a pharmacist verifying orders unless they were in California. So they just wanted to have clarification on that, on statement F.
That's it. So basically, it's just around the restocking, the technician, and also the inspections. Now, the inspection requirement, is that the clinic permit requirement that you're talking about or referring to?
So it's
Oh.
one, it's.
But
I'm
do
sorry.
we require them to inspect it?
Yeah, 4186D.
Okay.
It's in both. 40, yeah, in 4186D. It's also in 1261-6H.
But that's, 4186 is referring to a clinic, right?
Right.
So are these licensed to the clinic?
I can't answer that because they're not, we just provide the equipment for the pharmacies.
Right.
I
But
don't know.
But if a pharmacy was just to restock it and it was connected to the pharmacy, like an SNF, there's no requirement in our law that says an inspection has to happen.
So I think that, where needed is, can a pharmacy currently operate devices in a clinic? Or does the clinic itself need to
Right.
operate in it? And that's one of the things that we'll be fleshing out as part of our discussion.
And if so, what inspections are required?
If the clinic is owning it, under this, it has to
Quarterly.
be a monthly review of the machine. Then under the clinic, just general, it's a quarterly.
Okay.
So my question would be is if we could, if this, I think the monthly review is an excellent idea, but could a technician do the monthly physical review and the pharmacist do the quarterly clinical review?
Okay.
Anything else?
Thank you.
Uh-oh, how do I make this go away? I hate doing it on other people's computers because I tend to trash things and they get really upset with me.
I think we've got one more. as I
Thank you.
believe. Trying to find my list. We have Pharmerica. I think that's next. I think that's the last one. Is Pharmerica here? Yes?
Coming.
Good afternoon.
Save the best for last?
Absolutely.
Good answer.
All right, so I guess you guys can hear me. My name is Scott Anderson. I'm the manager of implementation with Pharmerica. And with Deborah Erlinson. She is our lead implementation consultant with this product, RxNow. So first off, I guess we want to start with, we like to make specify a difference between what we call an automated or electronic e-kit as opposed to electronic dispensing system or dispensing device. This along the lines of, with RxNow, is along the lines of a first dose and emergency fill medications. So what is RxNow? Again, like I was saying, we use RxNow solely for emergency dose medications and first dose. Actually, you can jump in.
Absolutely. Just it offers immediate on-site medication availability. We're able to actively manage the inventory that's contained within to ensure that we're stocking the medications that are suitable for the admissions that are coming in the skilled nursing environment. We're also able to generate and be prompted for refilling based on par level settings, so it allows us to know what we need to send to the facility. All stocking is done by a pharmacist. It's integrated with our pharmacy database and that the resident information is available, including allergy information.
Sorry.
Go like this.
So this is for first doses? First doses is what this is?
Yes, emergency and first doses.
Yes, ma'am.
Currently in California, just to throw the number out there, as I know the question will come up, we have approximately 30 machines. We have additional locations that are pending implementation, but we're not on the cusp yet. We have been complying with the new ruling in January of registering the machines in advance. It is more secure than a tackle box, and it allows better accountability for the nursing staff and for those that are, how the doses are dispensed and what occurs. We monitor the medication inventory, as I indicated, to make sure we have the right drugs in the machine. Also, removing medications. We're prompted for expiring medications, contains lot number information. All drugs in the machine are barcoded. We have a varying degree of medications to stock. So bulkier items are going to take up more room. So depending upon the volume of medications that we need to stock, we may start with 100, but we can increase that up to around 200 different labels. As far as capacity is concerned, to suit the needs of the residents in our rural facilities and locations that are 3 hours from the pharmacy where there's a physical constraint of being able to supply them with medications on a timely basis. We want to do what we can to make those medications available. There's the right drug barcode verification. The drugs are barcoded when the pharmacist stocks the machine. They're also barcoded when the nurse dispenses a medication. So if she claims that she's going to pull a Cipro and she pulls out a prednisone, the machine will prompt her that she has the wrong medication to try again. For controlled substance items, those are stored in that top compartment that's listed as a unit dose dispense module. That's a closed door system, coil style system, much like the representative before us spoke about. So the nurse only receives the doses that she's ordered. If she's ordered 2 oxycodone, that's what she has access to. There's nothing more. The nurse then barcode scans those items to verify that she did pull those medications out of the machine and closes out her session to go take care of the resident.
Now, you probably said this and I didn't hear it, but so if the nurse orders like 2 doses, does it come out like in a little, how does
Like
it
a
deliver?
drawer?
It's a unit dose. The medications that's stocked in the machine are in unit dose
And so
settings.
the 2 little unit dose things?
They're already
like-
pre-packed.
They're
Right.
pre-packed, yeah.
Right, they're
It works
pre-packed.
similar to a vending machine,
Machine?
like a vending machine.
Oh, okay. Oh, so it drops out?
So it
Yes.
drops
So
down
2
into
little-
the dispensing
2
tray.
little, okay,
Yeah.
thank you.
So the
So-
2 little doses come out in that manner, and then they're able to barcode scan them. Whereas in the other section, we have the drawers that allow for where your Levaquin's stored, your other medications are stored, as well as bulkier items in terms of Lovenox or other things that the nurse might need to retrieve on an expedited
The
basis.
drawers, are you open them up and it's the little cells that we've seen where it's multiple doses of something, or? is
If you
it?
can advance to the last
exactly.
slide.
Yeah.
Oh, sorry, I can be.
you're
No, no,
fine.
no. Just to show the compartment there, it's kind of small, so I apologize for
Okay.
that. But where you see the A, B, C, D, that kind of dictates the placement of the medication. But again, if the nurse scanned the wrong item, it would tell her you have the wrong med. We also go to great lengths to ensure that we don't stock, warfarin in the same drawer, multiple different strengths, or, similar medications are not stocked in similar areas. The nurse is only presented with the drawer, in the drawer section. She's only presented with the drawer that she requested the medication from. So specifically, that Levaquin drawer is what pops open. There may be other medications contained within, but they wouldn't be other varying doses of Levaquin. They wouldn't be controlled substances. They would only be, different medications that would be used on the first dose.
Yeah, it's important to make a difference or discuss it here. You'll see here at the top where it says unit dose module, that's where the narcotics are stored at. So no one, a nursing facility does not have access to that at all. It's something that strictly the pharmacy has access to. And then below that, you'll see where the drawers are at, actually, and that's where we would have your Legend drugs.
And the restocking is done by a pharmacist?
Done
and
by a pharmacist.
Is there any, I know we've seen those QB devices that go between the pharmacy and the machine. Do you have those, or is it just someone
because
physically
they're-
walking with a baggie and bringing
Well, I wouldn't say a
meds?
baggie, but it's secure.
Something similar.
Yeah, but something along those lines,
Yeah.
in that it's not the
Tamper-proof.
QB style system because it's
Yeah.
the manufacturer's unit dose or prepackaged from our side. You want to show the interior of the unit dose module? Last slide. Okay, that's a drawer shelf over on the right-hand side of that, right above recommended change. That's the unit dose module, the interior showing the coil system, the individual doses stocked one behind another, and just to kind of give you an indication of what that interior looks like. But again, the facility wouldn't have access to that area. It's only the pharmacy staff who have access to that area for stocking. It also is it's a closed loop system, so we don't have the staff interjecting, anybody going in there to count doses back or determine doses remaining. If we were to stock a medication in the lower drawer section that was a controlled substance, that item would be on a blind count, and those are only for things that are not tablet or capsule formulations. So the nurse is prompted to enter the number of doses remaining, but they have no indication of how many doses are supposed to be there. It's just how many are here. So if they enter any value that is different than the system value, then it flags that position automatically as a discrepancy, as well as notifies the pharmacy that there's a problem with this medication, and it will lock the medication from being able to be used again until a pharmacist goes out to determine, did the nurse make an incorrect entry, or is a med truly missing, so it was the user prior, or we have to distinguish between the two users.
So we've talked a little bit about functionality here. So to tag on a little bit more to security and access to this to the cabinet. Access is controlled by PharMerica. We create the users and the user profiles, so we can expand or limit the access to for a person to the cabinet. Also, too, you can access through a biometric scanner, also through a PIN, and of course, you have a username as well.
And when you say PharMerica, you mean the pharmacy?
PharMerica, yes. The
Okay.
pharmacy.
PharMerica.
So this is not, and the vendor for this is?
The vendor, well, the manufacturer of the cabinet, we've rebranded it as ARX now. The actual name of the cabinet was MedSelect Flex.
Okay.
Uh,
And it's also made
So it's
by.
MedSelect.
Arxium.
Okay, all right. Okay.
So,
No, I mean, I'm open to questions.
yeah, we're open for questions.
And
if you-
the pharmacy will then validate, is it is it a profile system where the pharmacy's going to actually validate what's removed on an order basis, or is it more just open where everything is on override essentially?
Because it's like an e-kit, it operates more like an e-kit in that the
Like
nurse
an
will be able
override?
to go in like a first dose and pull it. Now, the pharmacy is reconciling that information the following morning.
Mhm.
They receive a report every day at 8 a.m. that tells them everything that's been removed within the previous 24 hours so that they can verify on their side that they have the appropriate orders and documentation from the facility that substantiates that order.
And of course,
which we don't have with a tackle box. We don't have that same verification.
and of course, with narcotics, the facility would have to call the pharmacy for approval to access, to grab a narcotic.
And are the narcotics transferred to the clinic responsibility? Or it remains the responsibility of the pharmacy
Well, right now, actually, the pharmacy still owns the medication.
on a DEA form? So they're basically under the pharmacy?
Yeah.
Right.
But instead of, with your traditional tackle box, if a nurse were to pull a narcotic out of that tackle box, she would have to call the pharmacy, she'd have to fill out some paperwork for billing purposes. Because there's an integration or an integration between this system and our pharmacy platform, that's automated for the nurse. So we can determine who and when the cabinet is accessed. And also for additional security measures, if someone wanted to tamper with the cabinet, for one, it's extremely heavy. It weighs about
900 pounds. 900 pounds with nothing in it.
Yeah, exactly. So you put drugs in there, it's a little heavier. Can't really just wheel it out of there. You can lock the wheels, the base down. And on top of that too, it does have it has mechanisms in place to email. It could be right now we have it set up with the pharmacy, but it could be even with the facility. If they thought that someone was tampering with the machine, it would email to let someone know, hey, there is someone's
Diversion potential. It's an intrusion alert system that notifies that there's been a breach.
Exactly.
And it also happens, I mean, if there had been a mechanical issue, it would do the same thing. Because if any time that the drawer opens and it's not prompted electronically correctly, then it notifies the servicing pharmacy director as well as some internal departments within our organization to make sure that everybody's monitoring and knows what's happening.
How many of these units? You have 30, you said, installed?
We have approximately 30 that are currently live in the state, and then we have additional locations that are pending implementation. We have around 300 cabinets across the U.S.
Board member questions? Thank you very much.
All right, thank you.
Absolutely, thank you.
Ask one more question?
Yes.
I'm sorry. In your reference the 1261, also referenced F of the Health and Safety Code. Was there?
No, we just wanted to, in regards to that, when the cabinet was first approved by the board, I believe there was a Section F exemption so that it wasn't treated as like an automated dispensing system.
Okay.
So, and we just wanted to make that distinction. And just,
Okay. Okay, thank you.
And the only thing we would have left to ask is if you guys, I think we have the same sort of recommendations.
That you've heard echoed many times from the other
Exactly.
vendors who have spoken in regard to the automated e-kit type systems of, any flexibility with having technician restock versus a pharmacist, based on geography of a 3-hour distant building. What flexibility there might be for either a pharmacy technician, intern, or even nursing staff. We would also be interested in hearing the board's opinion.
Thank you.
Thank you.
Well, that concludes the vendor presentations for today. I believe we've got some closed session items. We're still waiting for, do you know when they're going to be here?
How close now?
They're on their way? I guess we will do we have any more public comment before we move on? Maybe, do you want to go over the decision items while we're waiting, and the decisions that we have to make on all these in terms of policy? Yeah, in terms of a policy perspective.
So as presenters have been going through, I've been trying to capture some of the questions that, some are overarching, some are a little bit specific to the devices. I think one of the things that I think it might be helpful to hear from is if the board thinks that there should be different decision-making, whether it's an e-kit or a full ADD system. Do you know what I'm saying? Those two different technologies. But with respect to the first presenter, there were questions about whether or not the board would allow a pharmacy to operate an ADDS system within a clinic. Currently, the clinic needs to own it. So, and then from that, there's, I think, bigger questions or more questions that come if you pass through that. Where do you go from there? Another thing that's been very, with that one specifically, was the issue of the wholesaler dropping the drugs off in a bin or whatever that's secured, and then I picture robot arms lifting things up in the pharmacist confirming where they're supposed to be going. So the stocking of it being done kind of remotely.
So one of the things that actually I was surprised just hearing today was what we're doing with a lot of this automation is we're basically extending the pharmacy walls outside of the pharmacy. So it's going other places. So it may be worthwhile for the board to consider licensing these locations if it is pharmacy stock. I mean, because we've heard several presenters say they're even storing controlled substances outside the pharmacy walls. So if they are asking for it to be tied to the pharmacy, should we be licensing these locations as locations that are allowed to have these meds and allowed to store them, especially with controlled substances going on? I guess that's a policy question where we want to go. Okay.
So, yeah, I think that's a really good thing to contemplate. And Jenny, I guess from enforcement, wouldn't we want them to be, as kind of Amy's framing it up here, isn't that maybe how we would want them to be licensed?
Part of why we did the registration for a portion of these machines, keep in mind, some of them today are not in an area where we register them, but part of that was to identify where they are. We didn't know where they were or how many of them there were out there.
But the registration gives us limited ability.
It does.
Because it doesn't allow us enforcement. Because if they have a license, then we could establish regulations and what they need to adhere to, right?
I think it's clearly something, yes. Well, you could do that, I suppose, right now, but I think that you've got a better hold if you've got a license. We do have the ability to cancel these registrations. But again, that is more just simply where are they without anything else. We expect the pharmacy to be exerting control over it. I don't know whether or not we've done it. We haven't pulled any of them and gone out to inspect yet.
Because in this day of technology, I mean, the ability to increase access by utilizing technology, I think is a good idea and it's a good thing, as long as it's done in a safe manner that protects our supply chain. So if there's a way for us to do this and still have technological oversight over what's happening and licensing them, at least the board knows where they are. We have more control over what's happening, even if it's not physical control. I think we have to get out of the mindset of we have to do things in an old-fashioned way. We have to get with what's happening now, and that's only best for patients because you can increase access.
But there's also the advantage that these devices offer better security and better features that are available for the patient as well, the convenience alone. We know that the patients like the convenience.
I mean, this is all about access, and I mean, that's
Absolutely.
like one of the biggest barriers is access.
And as long as we get the consultation provided and provide that mechanism by which you can do that, the primary needs of the patient that way can be met. But again, we just need to make sure our law's flexible enough to allow it or accommodate it as the technology evolves. And then two, we have the ability to regulate it, which
Well,
is
and we
where
don't want
Amy's
it
going.
so flexible, because still consultation's a big thing, so we have to make sure that it's, good, that it really quality happens, and it's not just call us if you have a question kind of thing.
No, it can't be that. And that's part of what we're still fighting within community pharmacy as it is.
I think we've got a problem with quality of consultation, period.
Yeah.
Regardless of where it's at. One of the, I guess, do we need to, is this legislation, or can we make these changes in terms of licensing these locations by regulation?
We would need a lot.
So, I think it would be legislation to license the location, but the one question that I have is that I don't think you.
Can't hear you.
It's on. There's a light.
Yeah, we can.
Hello.
You just got to get closer.
I'm going to eat the microphone. No. So, I think that the licensing of the location, I mean, that's an option. You would need legislation to do it. You don't currently have that. You have a registration process. But my understanding is that there's no location where one of these is stored where it's in control of a pharmacy, where it's not tied to a pharmacy's license. So from an enforcement, if the pharmacy was not appropriately managing the ADDS, then the board could still take action against the pharmacy's license. And I'll let Josh see if he disagrees with that.
Okay.
So you don't necessarily need an additional license, I guess.
But we do need some regulations or guidelines or something that spells out, if you're going to do this and it's going to be tied to the pharmacy license, these are the expectations of what is going to happen.
Well,
'Cause I
and
think
I also
that's still unclear.
I also think that there has to be a fair amount of coordination with Department of Public Health with regard to, placement in facilities that would be regulated by Department of Public Health, and who's going to control that list, or I don't know what's going to be done with that list. I don't know. You might need to hash that out as well.
Well, there's the Department of Public Health, but there's also been some machines that that aren't in areas governed by Department of Public Health. Like, you kind of mentioned to someone, is this going to go in the doctor's office? So, I mean, so we actually have two ends of the spectrum that we have to.
Well, and even further than that, I mean, I don't think it's beyond reason to think that somebody might want to place these in a mall, as a kiosk in a mall or something,
Yeah.
I mean, as an
And
ATM.
that's coming. We've already had a
Yeah,
request.
so not even around any kind of medical provider, yeah.
Exactly.
We've seen the request in the parking lot, so it's out there.
That's one of the questions is, what environments do you feel appropriate for, right? Heard there's lots of asks in here. We've heard the emergency room. We've heard, so we've heard the emergency room, the doctor's office, residential care facilities, assisted living facilities. So that we've heard the ask from several of them about expanding beyond what's currently allowed. So that is one of the
Probably not the
overarching-
local pub. I said probably
That's
not
a
the
liquor
local
license.
pub.
As long, I mean, I'm fine
Cookie
with,
store for you, but.
Yeah, it would have been.
I'm fine with the healthcare facility as long as they're providing some healthcare. I guess the other concern I think we need to look at is what happens when you transport the drug. I feel more comfortable with those tamper-proof devices where, like the QB, I don't want to just say it's like the QB system. I don't want to name any vendors,
Cassette.
but it's a cassette that actually is tamper-proof so that when you put it, you can't even put it into the device if someone's tampered with it. So it's very, I think, a lot more secure than somebody walking in there and hand counting it or bringing them in, because that's another area I think for diversion is the whole transport of the drug. So I think it's another point of contention that we need to probably look at. Maybe we could have, I don't know how we could do that, but the devices that actually can provide us with a tamper-proof chain of custody maybe fall under some, maybe a tech could do it, or have another process where other individuals besides a pharmacist that have to do it, while though, as long as a pharmacist has checked it in the pharmacy. But if it doesn't fall under this tamper-proof, then they would have to still have the pharmacist participate.
Is this
I mean,
a
that's-
licensing issue or enforcement issue, do you think?
I don't know, what do you think? What do you guys think, licensing or enforcement?
Enforcement.
Enforcement? Okay, why don't we put it on the enforcement agenda?
Okay.
To have them work out how we should modify some of these regulations.
Just to have a broader discussion and
Yeah.
kind of, we can maybe, again, work a little bit on that grid that was developed for you that, to summarize things, but specifically look at some of the components in there.
Because we seem to have certain types of technology that have been presented, at least today. I can kind of see the ones that service the patient, the ones that service the nursing homes or skilled nursing facilities, those that have the tamper-proof transport, those that don't. I mean, it seems like we're falling into certain buckets, and perhaps we can look at what we should do from a policy standpoint for each of those, from a restocking to a licensing.
Right, and be real clear about it specifically, yeah.
Does that sound good, everyone?
Yes.
Yeah, I think it's going to be enforcement, but at some point it might end up in licensing because there might be a licensing need also.
You can kick it back to licensing.
But it doesn't
if it does.
require another license.
No, it might.
The triggering mechanism, though, is an enforcement issue more than anything else.
That's where it should start. I'm just saying that we might end up.
Okay, so we'll refer this, now that we've got some information, back to the enforcement committee to come up with some recommendations on some of the laws. Steve?
Oh, thank you. Hopefully you get ready for some public comment. I think there's some people behind me that want to mention something too.
You know,
Oh.
We're
well,
having
maybe-
problems with the mics.
We don't have a quorum, so we're not an official meeting right now.
Okay, can I just?
Yeah.
Can't take action.
Yeah, we
Right.
can hear.
As Ann was going through some of the questions, I had a list also. I think something that would help that you might want to give to the committee, the enforcement committee, on this issue of licensing. So for an example, you had the presentation where it talked about the wholesaler delivers and then the pharmacist receives through a remote access where the robotic arms make sure they put it in the right place.
With or without the robotic arms.
Yeah, or whatever. I sounded fascinating to me. And I'm not speaking against it, don't get me wrong. But there is a regulation, 1783, that says that wholesalers can only deliver to licensed facilities.
Yeah.
So if you decide that licensing isn't necessary, then you may say, well, maybe it is, because then that will allow that to happen, and things like that. So there is an overlap somewhat.
so in that case, it would, I mean, I think we're talking about a different classification of license, right?
Right,
Yeah.
exactly. It wouldn't fit anything that I know of. And then the other thing I heard that you might want to, charge the committee to think of is that I think there was real confusion, maybe only in my mind, about when you do have a licensed clinic, a not-for-profit 501c3 licensed clinic that has been issued a license by CDPH and then subsequently a license by the Board of Pharmacy so that they can receive drugs. The drugs then, by definition, belong to the clinic. That was the whole idea. And two things to keep in mind then. Well, then, who owns the machine? And, and is that a situation where you also need a law change and if the pharmacy wants to own the machine? Because right now, it's unclear as to who is responsible. You remember you had the one company that said, well, they don't want to be responsible. We want to accept responsibility, and I'm not sure that it's clear whether that can be done. Again, I'm not sure.
You know,
And
to
it's
your-
not so much the machine, it's also the drug stock.
I was going
Right.
to say,
Who
because
owns the
that
drug
was kind of
stock?
his point, is that they didn't want to own the drug stock, I thought. First guy, the guy you're talking
Well,
about.
exactly. In other words, is it
No, but-
is it an issue of who owns the drug stock, or is it an issue of who owns and runs the machine?
No, he wanted to own the drug stock and
Yeah.
put it in a clinic.
Right,
That was
No.
his model.
right.
Rather than creating
Right,
a
right.
separate
So
license.
he wanted to own the drug stock and put them, yeah.
Yeah.
I think Greg had some.
Rather than creating a separate license, we may want to look towards legislation to supersede 1783, because now that we're stepping into this new world,
Yeah.
that legislation may be outdated.
Well, we also
That's a
keep
good
in
point.
mind at the next enforcement meeting, we are going to see the results of our pilot study that's been out there. You guys are due a report there.
And then lastly, just so you don't forget it, sometimes things get into the business and professions code, but not in the pharmacy sections, and so we tend to forget them. But in 2014, I believe it was, the law was changed for that nurses in these licensed clinics can dispense on their own authority anything that was prescribed by a licensed prescriber. And so that you do have that now as California law, that normally nurses cannot dispense. They cannot dispense explicitly in a pharmacy. They cannot dispense in a medical office. But in these licensed clinics, these RNs can dispense from the stock owned by the licensed clinic as long as they have a legitimate prescription / order for that drug.
Owned by the licensed clinic or owned by a prescriber in a
Owned by the
clinic?
licensed clinic. That was what the law change
Okay.
was. And
Okay.
for reference, that was per AB 2346 that went into effect January 1, 2013. And it's Business and Professions Code 2725.1. So, there's categories of clinics under the Health and Safety Code that are allowed to get this license from the Board of Pharmacy so that they can buy and own the drugs. And there's a not-for-profit clinic that's owned by a not-for-profit organization. There's a free clinic. There's clinics owned by the government. There's clinics owned by a tribe. There's several categories that fall into that under this Business and Professions Code section I read, where since the drugs are not owned by the prescriber, they're owned by the clinic, the nurses that work in those clinics, and most of them do not have a pharmacist, then those nurses can dispense those drugs. And I think it needs clarification also while you're looking at that, if you choose to look at it, when they dispense the drugs, do they have to follow all of the labeling laws that a pharmacy would? And do they know that? We know that a physician, when a physician dispenses from his or her own stock, they have to follow all the pharmacy labeling laws, with one exception. So it's not clear to me that that's well understood about when nurses dispense from those clinics.
Do you know why it is that in a physician's office, an unlicensed person can authorize a prescription, but a nurse in a can't dispense? Doesn't seem to.
So if I understand your question, Greg, you're saying in a medical office, which is a physician's office,
right?
Why, if a agent of the physician can call in a prescription to the pharmacy, but that agent of the physician, even an RN, cannot actually dispense the drug? That the
Right.
drug has to be
It
personally
doesn't
dispensed
seem
by
to
the
make
physician?
sense.
That's just because that's what the statute says, and that's been there probably
For a
40
while.
years.
Yeah, for a long time.
Well, I think it all came about when the doctors went on strike years back. And then they said that, for people that needed the medication, the people in the office or the agent could authorize it, and then they never took that away. But it just doesn't make any sense to me that a nurse.
Well,
who-
one is
Yeah.
dispensing, and the other is just
I
transmitting.
understand.
So I think there's a big difference between allowing an agent of the physician to actually, because then who's going to do the consultation? Who's going to do all of the other? I just think there's a
Right.
big difference between transmitting a
Good
verbal
point.
order on behalf of a prescriber versus actually dispensing on
But
behalf
they
of a
can
prescriber.
authorize controlled substance. Well, they can't sign for the, okay.
Thank you.
But they could do tramadol.
Hi, everyone. Robert Stein from KGI School of Pharmacy. As an informaticist, I think I might be able to ask the board to classify these devices. And I think, Amy, you actually observed that we're looking at different sites where these devices are placed, and we're looking at different functions. Some of them are dispensed to a consumer, some of them are dispensed to a healthcare professional. So perhaps maybe the board or a committee of the board could develop like a white paper that basically has a matrix of how these things work, and then you can start to go, okay, this one looks like it needs a license, this one
Right.
maybe not.
And I think that's where I was going. It's about like a grid where we actually have these in different buckets, and then we can determine, and then if there's any changes that are required to the law to help enable them to be able to provide access.
Yeah, because the law is currently
Mhm.
has been really kind of schizophrenic all
Mhm.
over the place as
Mhm.
far as what an automated dispensing device even is.
Right.
It's funny because I wrote down some notes during this, and you actually stole one of my thunders here, which is a tamper-proof, opaque container that uses an electronic mechanism, so you don't even know what's in it. It's basically just a plastic box. And when it gets plugged into the dispensing device at the location it's going to, that identifies it uniquely. We know it's the correct drug because the pharmacist on the other end verified it and
confirm
identified
it.
that particular cassette or whatever you want to call it. The other comment I have is on these 24/7 dispense-to-consumer devices. They talk about, oh, you have a way to contact a pharmacist for consultation. If these are 24/7, presumably the pharmacy where these are located are not 24/7. Where's the pharmacist that's going to consult? Anyway.
Well, so
Good
I
question.
guess I'm picturing in that case that it's just like a remote pharmacist,
Yeah,
don't
they
you
have
think?
that.
Like, maybe like a pharmacist that works like in a 24-hour store that then would, you would ding, and it would, circumvent it over to a pharmacist. Are you questioning if they're within the state or?
Not so much. I mean, I think that's a bigger picture, but, definitely the question, and can an employee of, I'll just use the frequent chains here, can a pharmacist at CVS go and counsel a patient at Walgreens
No.
in one of these devices?
No, it would have to be, they'd have to ding, and it would have to go, if it's a CVS, it'd have to go to CVS.
They have on-call pharmacists doing things like that, don't they?
Yeah.
Yeah, I mean, because right now, if you called one of the chains of 24 hours, they usually will say, if your store's not open, hit number 3, and then they'll be circumvented to one of that chain's 24-hour pharmacists.
Right. And
But I
then,
think that's a good question, is what's the pharmacist access for after hours? How's that going to be delivered?
and then one other thing, again, counseling is one of my bugaboos too. If you are just looking at a patient on a little video screen, I think when we counsel face-to-face, we pick up body language, we pick up all sorts of things that we cannot do in this remote environment. So, again, I don't want to sound like, a Luddite, but I think we need to
What?
consider.
You're
Exactly.
just too old, that's all.
All right, thank you.
Thank you, Robert. Any other public comment? We have one more.
Gracious they are.
Charlie Hardig with Omnicare and CVS again. I was taking notes and getting ready to attach them save them in my computer file, but I would be remiss to say that I didn't hear 2 takeaways for the enforcement committee, and I just want to make sure that those are at least considered by this group, and that is the nurse replenishment, which I think many of the vendors have discussed. So I'm hoping that the enforcement committee at least would entertain and take up section 2161.6G 1 through 3, just to discuss
That was
as well.
something that I had mentioned when I talked about the fact that what's the security of the transport? So if it is secure and if it's in, and I like what Robert said, what is that? Opaque, tamper-proof container, that may have different requirements for, that's what I'm suggesting.
Sure.
Than when it's just basically brought where anyone can open it. So that's why where that came from.
Yeah, I just want to make sure it's on the agenda for the committee to consider. The other consideration was, in our original request, was the memorialization of pharmacy employees able to stock. It's our understanding that is currently the position of the board and the committee, and
Yeah,
I
it is.
see a head shake.
We had our attorneys opine, you may not have been in the room.
Okay, sorry about
Now,
that.
I noticed too, and now going back to this Omnicare, and I had some comments and questions before that I didn't raise because I thought we were going to talk about it later. I noticed that there's some discussion in here about stocking the container and the facility, what they would do in terms of the restocking and such, but I would actually like to see this expanded to where the facility is also responsible for monitoring and making sure that they monitor the device and they also have some process in place to report drug losses.
And that all those things happen with our vendors, one of which presented today that we normally use. We do have implemented blind counts. We do also do we call them discrepancy reports, but it's a prefab report from the automated dispensing system. we use the compartments and containers that open only upon a patient profile. So many of those things happen, and I didn't want to detract from the vendors today because I think that was the intent of the
Right.
meeting. But what you'll see as you walk through all of the different vendors is they all have vastly more superior security features than what has been used over the last 30 years.
Oh, absolutely.
And because of that, I just would hope that the committee and the board does not consider those apples to apples comparisons, because they are absolutely not. But I think that because of the security, because of the auditable log features, and because pharmacies use those to not only detect diversion, but also just ensure that drugs are placed in the right containers, barcode to barcode scanning more particularly, and others have RFID technology. Those types of things really cut down on human error. Not really, I mean, almost essentially cut down on all human error. I can't speak to to each vendor system, but I mean that is one of the ultimate goals, and that's why these technologies are so innovative, and companies like Omnicare and CVS use them.
Yeah, I heard a couple vendors today that something I really liked, where if it is tampered if there's any tampering at all, it does not even let it go into the device, so you can't even place it there. So just the fact that that's there, I think, helps us in terms of our oversight of whether it's been tampered.
Do you know if they do if most of them do scheduled maintenance on the software to make sure that it is continuing to work properly?
I can't speak to each specific, but there are software updates that do occur. I don't know on what schedule or if they're regular or periodic.
The great part about this too, Greg, is that you can get so many reports on usage that you can do trending, and you can look at all this data on what's happening that you're really limited to with the tackle boxes. So you can actually see what's happening. So it gives you an insight. I think we just need to tighten some of the regulations to prevent diversion, but other than that, I think it's a great idea to move forward.
And I would also add, you discussed, there's a couple topics that you had hit on that I wanted just to provide additional comment. Section 1250 of the Health and Safety Code currently provides this framework of who is allowed to have an ADDS in their facility, I think with the exception of clinic and primary care clinic, is my understanding.
That's the general code for licensing healthcare facilities,
Yeah, so
which is the purview of the Department of Public Health.
Yeah, but my understanding is that is kind of the scope of where ADDSs can be placed today. So when we were talking about the hypothetical parking lot situation, is my understanding that only those facilities licensed under 1250 are allowed to have an ADDS. That may not be,
No, I think it's a little broader than that.
Okay.
Prisons, for example, are using them, or jails
correctional
are using
facilities,
them. And
sure.
I'm not sure where the authority is for that.
And Jenny, you brought up a good point, which is that we really do need to work with the Department of Public Health.
Oh,
To
absolutely.
encourage them to also be at the enforcement meetings when we start developing these regulations. So we make sure we do align both of the departments together.
And then the last point I just wanted to make was the ownership of drugs in the machines. I would caution any statutes or regulations which would require a clinic or a pharmacy or a long-term care facility to be the specific owner of those machines. I think it would have a chilling effect on the adoption and use of those machines. When pharmacies service facilities, either hospitals through a management services contract or a long-term care facility or other types of facilities that are allowed to use these, they need to do that. Deciding who owns the machine is a very case-by-case specific issue, and allowing pharmacies and facilities, whether they be correctional facilities or clinics or SNFs, to do that is really a case-by-case basis. So any regulations or statute which says pharmacy must do that, must own machine, or clinic must own drugs, is potentially problematic. For example, non-charitable clinics probably don't have the resources in some cases to own, the number of drugs that some of these machines can hold, and they can't carry, and they can't particularly probably buy the medicines at the prices that some of the pharmacies are able to get them in terms of negotiated contracts. So that might be requiring that type of or mandating that type of restriction may be problematic and may chill the effect of using these machines in certain settings.
Maybe, but there's another side to that too, that where the facility has inpatients and they do not themselves own the drugs, we have seen cases where hospitals have been held captive by the provider of the drugs, that either you pay me or we're going to have all the patients removed from the hospital, and you never want to do that.
Sure.
And for that reason, we make certain that the hospital owns the drugs.
Understood. I was just showing the other side of the coin to that.
But you do not want the patients put in that kind of jeopardy.
Thank you.
And Goldenberg, first of all, congratulations. I think that this meeting was extremely successful. Successful in the fact that you brought together Department of Public Health, vendors, and yourself to understand what's happening with technology. As you know, I'm constantly working in the field, and I think Amy came very close to what I was here to suggest. During the enforcement meetings, it may be of value to dedicate a certain time at certain meetings, a few times a year, to have technology people come and explain what's happening. As a for instance, in some of the meetings that I've been in, there have been discussions about drone delivery of medications, whether it be drone,
Like flying?
like flying drones, whether it be within a campus, whether it be from a wholesaler to a pharmacy or a pharmacy to a client. Technology is just moving so quick that for elderly people like myself, sometimes I need to turn to other people to get explanations. You have an opportunity here to have, as we talked at the last time, where together we can do more, to have people present their thoughts and their ideas to you so that you can help them create a product that not only helps the patients, but also provides the security that you're requiring. So thank you again for this time, and anytime you want to let it stop raining, it's okay with me.
So Stan, I have a question for you, because you seem to be kind of one of those technology kind of guys. So how often is it reasonable, like once a year, kind of, I think that's a great idea, maybe to add it to enforcement and just kind of get a...
I would think to start off twice a year until you see what's presented to you, because these things happen very quick. 5 years ago, how many automatic dispensing devices were in skilled facilities versus today? A lot of things force this. And so that would be my suggestions. And if you see that 20 people come to the meetings twice a year, you may want to go 3 times a year, so 10 could come. Good.
Then it's once a year.
Right, right. You know what that saying, if you build it, they'll come? You may be surprised. Okay.
Thank you, Stan. All right, we are at the conclusion of the meeting, and we will now go into closed session.
And before everyone goes, those of you that may be interested, we are doing one of our long-awaited, at least I think they're long-awaited, drug diversion, prescription drug abuse seminars or CE sections on March 11th at UCSD. You can get 6 hours of CE, and if you stay an extra hour, you can become certified to dispense naloxone. So registration, I think we still have about 70 slots left as of last Wednesday. So 250 people are coming. So it's free, and you're welcome to come. UCSD, DEA, and the Board of Pharmacy are all co-presenters. And I've run out of...
Well, look, I'm just reading that the Grapevine looks like it's reopened now. All lanes are open. Some of us may be driving back.
We're going to move it around.
There's one of our board members actually was at the airport and is supposed to take a 3:15 flight, and it's now on weather delay. So it may not even go. So if you're taking a flight this afternoon, you may have an issue at the airport.
Sorry.
Yes, yes.
All right. Session, we're going to be discussing pending litigation. The first one is Santa Clara County Superior Court, number 16 CV 302071. Second case is Sacramento Superior Court, case number 34-2016-80002456. We're now in closed session.